Hi, thanks for joining us for CDC's webinar today entitled Conflict Management in Times of Competing Resources and Priorities, hosted in collaboration with the Society for Healthcare Epidemiology of America, SHEA, as part of the Joint Outbreak Response Training Program, ORTP. I'm David Bannock from the University of Connecticut School of Medicine, and will be moderating today's webinar. This webinar is the second of the Effective Communication webinar series designed to train hospital epidemiologists in the interpersonal skills important in an outbreak situation. To find out more about the ORTP, including more information about our upcoming in-person meeting, please visit the website ortp.shea-online.org. Questions can be submitted and will be asked at the end of the presentation. This is the second of 3 webinars. The next webinar will be on July 11th from 12 to 1:30 p.m. entitled Beating the Media Crush During a Crisis, and will be given by Taylor Wilson from the University of Nebraska. Today's speaker is Dr. Stephen Weber. Dr. Weber is the Chief Medical Officer and Vice President for Clinical Effectiveness at the University of Chicago, and an Associate Professor in the Section of Infectious Diseases and Global Health. At the University of Chicago, Dr. Weber has served in a number of leadership roles focused on clinical quality and patient safety, including Chief Healthcare Epidemiologist and the Medical Director of Infection Control and Medical Director of the Center for Quality. In 2009, he was elected by the clinical faculty to serve as the President of the Medical Staff. His primary focus of investigation is the prevention of infection by multi-drug-resistant organisms among hospitalized patients. So Dr. Weber, thank you for presenting to us today.
Thanks very much, David, and thanks everyone for joining, and thanks also, of course, to SHEA and CDC for the sponsorship. You know, as I'm getting started here, I'm seeing some comments coming in about issues with audio, so I know the folks who are handling the tech on this, please provide comments or feedback if you're hearing. It looks like it's getting fixed. All right, good. Well, again, welcome everyone, and thank you for spending the time with us this afternoon. This session is I think, in fairness, a little bit different than the other 2 that are part of this series, because in this case, we're trying to put that communication element that David mentioned into the context of how we run our programs, how we think about infection prevention healthcare epidemiology programs. And notably, I think, when you look at the title, which might otherwise seem relatively non-specific, the word outbreak doesn't show up there. The word epidemic doesn't show up there. And that's very much deliberate. The reality is, what I hope we can do over the next hour or so and then discuss with some questions is really frame up an approach to communication and leadership that's embedded in the structures of the organization that serves us well, not just in times of crisis and outbreaks and epidemics, but as well in our daily routine that again, that all of you have stepped out of today to join the call. So why don't we go ahead and get started. When we think about the objectives of the discussion today, you know, there's sort of a wordy version that's on your screen, but let me translate it for you so you know what to expect over the next 55 minutes or so. I want to talk about the who that's really involved, the who in our programs, in our institutions and outside our institutions, the folks that we need to collaborate and communicate with to be successful. The next is the what, the planning that we need to do, how we embed ourselves as professionals and experts to ensure that when the call comes, when the urgency arrives, that we're best positioned to really exert that expertise and serve our organizations and patients well. And finally, the how. When we're in the moment, when we're in the circumstance, what can we advocate for in terms of structure and process in advance that will actually set us up again for success? So it's the who, it's the what, it's the how. It's also, you can look at the pre-planning phase, the planning phase, and then the execution and action phase. So that's just the way we'll look at it as we go forward. But again, we'll move through it in continuity, but then when we go to questions, happy to go back and go over any of this in more detail, because with a scope like this, as this audience can appreciate, it's hard to go too deep on any one subject as we go. So we'll look forward to a robust question and answer session. So just by a little bit way of introduction, this is sort of the gratuitous introductory slide about my home institution where my experience has been formed, and I've helped develop my own expertise, but really under the tutelage and collaboration of my colleagues with whom I work. We're not that different from probably some of the folks that are on the line. We do have a very pronounced teaching and discovery mission, but you see where we sit by the image. We're on the south side of Chicago, sort of the leafy part of town, and in doing and being that position has really given us quite a bit of exposure and understanding some of the issues that we'll talk about today. What about our infection prevention program? It's a real source of pride for us here in Chicago. The details are laid out there. We have an astonishingly effective full-time nursing director who's been here over 30 years now and has a leadership position regionally and nationally in a number of subjects, but also her work and the work of the 8 or so ICPs and support staff is really built upon with the physician leadership we have. Right now we have 1.8 faculty physician full-time equivalents. Folks say, well, you know, what do you do? How do you line up to make sure you're as well-resourced and blessed as we feel like we are? The first step, I think, seems to be to have a chief medical officer who's a former healthcare epidemiologist and infection prevention leader, because, again, this is not a place we're looking to scrimp. So we recognize we're blessed, but we hope to, and I hope to present today material that's going to be applicable no matter how blessed you feel right now with your own staffing and with your own resources. Our activities are typical for what we see across the country for robust infection prevention programs. And organizationally, something that I'll come back to is what I think is a key element of success is we're structured with the infection prevention program reporting through the Chief Quality Officer. The CQO reports directly to me as the Chief Medical Officer, but in putting the group into this umbrella of what we here call clinical effectiveness, puts them alongside and in tight alignment with our teams in performance improvement, risk management, until recently business continuity, and a number of other work units that really allow for a bit of a fraternity between these groups of driving towards improved clinical outcomes and success. And that placement, I think, is really essential and one that we'll come back to as a key feature as we go forward. You know, just to kind of add in, I deliberately call this slide Disclosures and Revelations because in some sense, we kind of feel like we've been at the epicenter of a whole series of biblical events over the last 20 years or so that have us asking the same question that the infection prevention professionals and healthcare epidemiologists at your place say, why us? Why is this happening to us? For us, when we ask that question, we're thinking about early detection of community-associated MRSA, something that our pediatricians did here now over 20 years ago. To the upper right of the slide, a young child with severe eczema exposed to smallpox vaccine before his dad left for the Gulf War, who developed and came in with eczema vaccinatum. To the lower right, unfortunate, a sad story of a local investigator, basic scientist, who actually died of overwhelming plague in our emergency department. And then finally, to the upper left, you see some of my colleagues and teammates training and simulating here around Ebola, because as many of you also learned, we came to be familiar with the daily flight schedule of direct flights from West Africa to O'Hare Airport because we felt like we were on the front lines and ultimately took care of more than a handful of patients with suspected or possible Ebola, all of them ultimately excluded, but for those who've been in that position, you know that small comfort when you're in the moment. So this has been our experience. These are our bona fides in many ways in terms of why we feel like in a group of peers like all of you, it might be helpful to have me share some of this. So let's go ahead and dig in, and we're going to start with the who. I don't mean to be negative about perils in partnership, but it's an understanding of well in advance of an event. How are we setting the stage in our relationships, in our teams, internally and externally, to be successful and effective in an outbreak setting? You know, and for that, I'll draw upon a principle that's anchored with the Chicago School of Architects, the modernist architects typified by Louis Sullivan, who actually coined this phrase. And purists, I'll need to acknowledge, folks joining from Western New York will identify the Guarantee Building is actually in Buffalo, New York. But Louis Sullivan and colleagues, actually, I identified this notion of form following function, that whether you're talking about designing an office building or home, an object or a tool for use, or in our context here, a team to manage an infectious outbreak or epidemic, that you need to design the team to meet the needs that you want to have. You start with the function. What are we trying to do? And then you design the team around that. And so as I go through the next couple of slides, I'll try to highlight that point. The idea of what are we trying to do when we're establishing the position of an infection prevention program in an organization. So I gave some examples here, generic examples on this slide. Authority. Does your infection prevention program, not at the setting of an outbreak, not in the moment of a crisis, but do you have the statutory authority, either externally or by internal policy, to say that you and your team will have the final word about the safety of patients around infection prevention? Put simply, can you be outvoted by another department or even an executive in the management of infection? Are you tied to operational plans and strategic planning? Are you embedded in the work of determining where the priorities of the organization will sit? Are you placed in the right level in the organization to have access up and down the chain of command? In visibility and accessibility, I like to use it as a little bit of a shorthand, this idea of an organizational all-access pass. It's sort of a quick shorthand to understand if the infection prevention healthcare epidemiology program has the access and visibility that they need. And put simply, it's this. Does your ID, your swipe badge, or your key set, is it a master key? Does it get you in to every room, every place, every operating theater in the organization? Because I'd submit to you, if an infection prevention program is blocked access to any of the geographical places in an organization, then you've got more than just a geography or a lockout situation. You actually may not be sufficiently placed in terms of the task ahead, whether it be emergency or routine. None of our programs, as skilled, resourced, and expert as you might be, practices on an island. And so there's been a lot of thought looking at what's the collaboration, the overlay, the reporting relationship between programs like clinical quality, lean, risk management, safety. I don't have a clear answer for that, but these are the folks that you need to be collaborating with in partnership, not in an adversarial or competitive relationship, but it needs to be sorted out. And I'd submit to you it needs to be sorted out well in advance of any other kind of event. I think increasingly, whether on the theme of epidemiological circumstances and infectious outbreaks or the risk of ransomware, our close collaboration with folks and experts in business continuity and emergency planning really come through. And I know there's some folks out there listening to this who have that background, have that expertise, and it is another whole discipline. So what I'm doing today is the perspective that many of us share as infection preventionists, as healthcare epidemiologists, ID clinicians, but do understand and do respect and recognize that the expertise that comes with folks who do full-time business continuity, that's an expertise you want to tap into, and you want to have those collaborative relationships. And what does it look like when that's the case, when you're really well placed? Well, then you've got relationships within the organization that look like this on the next slide. And again, not everyone perhaps will think of infection prevention in the middle of everything, but I think for this group we can leave it at that. But it's these connections throughout the team with everyone from food service to physical plant to laboratory to nursing. And one thing that needs to be brought on here is these are interpersonal connections and considerations. These are relationships that need to be built. However, the relationship between the programs and the work can't be entirely predicated on those friendships and colloquial relationships that we might have with folks. And I just bring that up because it's not to devalue the urgency of having professional, collaborative, collegial, friendly relationships with folks. But when the work needs to be done, sometimes those discussions and sometimes those asks may demand us to go beyond some of those relationships or put stress on those personal relationships. So keep that in mind as you look at it. You want to foster and build these relationships, but those friendships can't always come at the expense of what needs to be done for our patients. You know, we spend a lot of time as professionals building and cultivating the internal relationships to our organization. But let's just take a moment and examine the relationships outside our organization, because when it comes particularly to emergencies and epidemic preparedness, all of a sudden these relationships become at least, if not more important. The roster that you see on the slide here is really a limited set of the folks and the entities that we interact with at the University of Chicago in the setting of not just these emergencies, but on a routine basis. And I apologize if Mayor Emanuel or any of your family is on the line. That's not the most flattering picture of you, but working with the municipal leadership becomes essential, the local politicians. Working with, obviously, the departments of public health, from CDC to state to city to those relationships built in advance of these events through knowledge sharing, through collaboration, through transparency is absolutely essential and pays dividends in the moment when the emergency comes up. There are folks that are listed here on the slide that we would see from a business standpoint as our competitors. But at the same time, when faced with epidemics, for us, organizations like Northwestern, like Access Community Health, like Rush, become our closest collaborators and co-conspirators. And I look specifically the work that was done, and much of it led out of Rush in the Chicago area, Ebola response, was just really an astonishingly effective model, but that one that was predicated not by the urgency and emergency of what was happening with Ebola patients, or potential, as it were, Ebola patients coming to O'Hare, but rather with the collaborative relationships and transparency that have been set up well in advance of that event. So as you look across the landscape, whether you're in a big city or smaller town, critical access, large urban academic medical center, if you don't have on your cell phone, on your office phone, the contact information for your opposite number at these other organizations, that's something you can tackle today that's going to, again, pay dividends in the setting of an event. So we've talked about the organizational structure, the form follows function, and what those relationships ought to look like. We talked about the external relationships, and in some ways how those can sometimes be neglected. Yeah, but let's just take a minute while it's just the 800 of us or so and take a minute to reflect. Because fundamentally, much of how we are effective as communicators is going to be contingent on our attention to the things that I think are on the screen right now. And again, this isn't to cast aspersions on anyone, because again, the fact that you're joining, taking time to do a call like this, says your investment, your involvement, but we need to look at ourselves and our effectiveness and our internal brand in many ways within our organization or across the region to understand how effective we're going to be. Credibility. Ask, do I have and demonstrate expertise? It's not enough to sit quietly in the room and know that you're right. Do I speak up? Can I assert myself? But when I do, is my information and knowledge up to date? The time that we spend on continuing education, collaboration, teaching and education by whatever means necessary is essential, because the moment we get scooped in our core content expertise by someone else inside or outside the organization, our credibility has fallen a notch. And that's a lot of pressure for all of us, because this takes time. But the reality is it's time well spent when things really get going. Reliability. Am I present? Am I consistent in or out of crisis? That internal consistency is really a key feature, because if it's your management style to drag your organization from one crisis to another, the sky is falling today, it's CRE today, it's C. diff tomorrow, it's disinfection the next day, that's going to be very, very hard to manage when it comes time to real-time sensitive crises. That's not to say those issues, obviously, to this group are not significant, not important, not a risk to our patients, but can we be consistent and level-headed in our work? And finally, approachability. And a big part of approachability is flexibility. We want people to understand that we're speaking for the safety of our patients and our families and our teams and our staff and our visitors, but at the same time, too, we can't be so predictable to have folks feel that we are going to be so hard-line on one particular policy or regulation that it's not even worth asking us anymore. And that's hard for a lot of us to get through and get over. It was difficult for me coming through in my career. But as we go forward on this group knows, looking at the roster, many of the folks on the line, that we need to be ready to listen to new ideas and concerns, and particularly when we get into the kind of events that we're talking about in this series, because often in those cases there's not an existing policy and there's not a best practice already established. And so that flexibility becomes key. So that's the who. Those are things that if you hung up the call right now, which I don't encourage you to do, but if you hung up the call right now, you could start working on those items and relationships right now by yourself. Pick up the phone, talk to a colleague, and start going on it. Let's get to the what. which is the planning, anticipating needs in the time of crisis. This is one of my all-time favorite quotes because I think it's also reassuring in some ways or it can be reassuring to people who are a little bit of procrastinator, but that's not what the intention of the general and president was. Plans are useless. It's the planning that's indispensable. This isn't a nihilistic or fatalistic view of endlessly spending time creating plans and binders and shared files that never get opened. It's the realization that our best plans foster collaboration, they foster flexibility and adaptability because, especially in the domain in which we all work, we can't predict everything that might be coming down the road. And even with new tools, resources, and networks to detect emerging pathogens, early warning systems for outbreaks and epidemics, the fact is the next thing that affects the American and international health system from an infectious standpoint may be something we're not even familiar with today. And so our planning, which brings together our team, our planning which challenges us to be effective decision makers, is much more valuable than the prescriptive information around one single pathogen or one single approach. Planning for these events is time consuming. Planning for these events can feel like a distraction when you're staring down an accreditation visit, when you're staring down the daily routine of surveillance, the daily routine of policy making and enforcement. But fundamentally, planning needs to be done. And I draw as an example here another organization, the federal government, who embodies, in this one case at least, a key element, and for me, the starting point of all of our work around planning, and that's risk assessment. Risk assessment is the cornerstone. It's the foundation, the starting point for our planning. And if you think as a team, no matter the resource base you have, no matter the experience you have, no matter the time you have, if you think you don't have time for risk assessment and planning, I think you're wrong. And look at it this way. If the federal government on a periodic basis can put together, and I'm going to just pause for a second because I'm seeing a lot of folks reporting that the audio has gone out, in which case no one can hear me right now, but I'm going to keep talking and I hope that folks are joining back on, and I apologize for the technical difficulty. I hope my colleagues supporting the technical side are able to get to it. Thanks for those of you on the phone who can still hear me. All right, we'll continue on. The federal government on a periodic basis assesses worldwide threat, all risks to the U.S. through the intelligence community. That's a much broader charge than any of us could be asked, even in the biggest organization or the most vulnerable organization. But think about risk assessment. It sets the stage for all the future planning because it's identifying the needs and the allocation of resources and expertise. The process of risk assessment brings together key stakeholders, and this is a place where you're really going to understand your new and emerging threats. Now, that said, we don't need to devote the same kind of resources and I suspect bureaucracy that goes into the federal risk assessment. And I just point you to a very simple tool, a semi-quantitative tool that we've applied in varying forms over the years. This is going back a few years. To look at how we think about risk assessment around outbreaks at our hospital and our health system. First of all, keep in mind that infection control risk assessment, not just a good idea, it's kind of the law if you look at accreditation standards from the Joint Commission and others. But the idea here is to take a document, take a group, and sit down together, and as you follow with me here, across the top, what's the likelihood of a given challenge during the upcoming period of time? Maybe it's particular multi-drug resistant organisms, device-related infections. But what's attractive, I think, about this kind of semi-quantitative methodology is it lets you build in other things, too. It's not just limited to specific infectious classes. So here, regulatory, and then the emergency planning, the focus of this discussion. So what's the likelihood on a scale from 1 to 10? In this case, during this time period, the organization said, we think MRSA is a bigger or more likely problem for us than VRE. The number affected, the scope of who would be affected. In this case, there was a determination that C. diff infection was going to be more likely than CRE infections. And in this context, these numbers were generated by that group, by that multidisciplinary group coming together. The next column, how severe would this be? How bad would it be if we had a cluster, an outbreak of CRE? And in this case, the group determined that CRE was among the scariest of the MDROs that we'd see, and the difficulty in treating them would be an absolute challenge. And then lastly, and most importantly, is that self-reflection of how vulnerable are we to this? Because maybe we feel like we've already got tools in place for VRE, so a low vulnerability score, but for CRE, not so much. Take that, in this model here, it's a multiplicative model, and it ends up that you can quantify by multiplying the numbers together from left to right into a total risk score. Look, these are not evidence-based. They're not externally validated, but they're allowing you, at least internally, to sit down and not get driven by what's the last thing that we experienced, what did our board member's son get sick with, what's the most vocal physician leader most concerned about. It lets you look and prioritize. And again, what I think is really attractive when you come down here, you can take, in this case, and say, even for these really unlikely events, pandemic flu, deemed to be unlikely that time period, a lab-related event like our plague case, very unlikely, but what would be the vulnerability and severity could be very high. You got fair to middling scores for those, but what's the likelihood that we'll have some kind of infectious emergency over the next year? In this case, it was rated a low to medium likelihood. The number of affected could be high. The severity could be high. And the vulnerability, if we haven't done the planning we're talking about today, could be very high. And so you end up with a portfolio of priorities for the year that, in this case, if we looked at it, might be initiatives focused on C. difficile, CRE, Joint Commission readiness, and unknown emergency planning, meaning to an unknown or as yet undetermined pathogen. Again, I apologize, but appreciate the persistence of the folks who are working on the audio, and we'll carry on as we go through here. So having done this kind of risk assessment, there's certainly a stage around policy and protocol that you develop, but let's go forward to putting that risk assessment in action, to sitting down and understanding what it would look like when those events happen, okay? So simulation. You can look to all different levels of simulation, and there are experts across the country who do work in high-fidelity simulation. I don't want folks to be intimidated by the notion of simulation. Sometimes that language itself can suggest a degree of planning or expertise that you might not all have. Now, is there a benefit to that more intensive simulation? Absolutely, and we've been fortunate to take part in a number. Many of you, more than a decade ago now, Operation Dark Winter, looking at smallpox, a nationwide simulation. We repurposed in the upper right some undeveloped shelled space in a new hospital building, which became, you can see the styrofoam walls, our Ebola training and simulation space. Again, not high fidelity, but still allow people to get in and play with the physical space. But more often than not, we're taking people away to a place like the Booth School, our graduate school of business, away from the medical campus to sit down and tabletop this out, to get away from the distractions of our routine and say, what would this look like if it happened here? Ideally, there are professionals, agency folks that can help sponsor these, but they need not be elaborate. It's the work going into not only planning it, but then sitting down and talking it through. And what you want to do, you need a scenario that's going to be specific. Maybe it's about, as Dark Winter was, it was about smallpox, but to take the generalizable skills. And I'm always reminded that the first tabletop I did, and I was as green it could be coming out of my training and becoming a hospital epidemiologist, we did a tabletop simulation where what we found ultimately was that everyone in the room was referring back to me as the hospital epidemiologist. Here I was, not long out of fellowship, and everything was coming to me as information overload, confusion, and it informed us right away. I don't even remember what the topic of that simulation was, but the notion of saying that if you try to filter this kind of information through one person, no matter how experienced or inexperienced they are, is not going to work. A valuable lesson, even though I can't recall what the disease matter was we were talking about. So simulation is going to open the door to some of the needs and gaps that you have as an organization. And let's go through that a little bit more about the what that goes into this kind of planning. And we'll start with equipment and ventilators. And for each of these, I'll adopt this format of stockpiling, flexibility, and collaboration. Look, there's probably, we've all had or we will have a moment where we wish we had stockpiled more equipment. The reality is with capital budgets at your place are probably not much different from mine, resources, storage, and others, not much different, that it's probably not prudent or economical to stockpile large numbers of critical equipment. It's just not going to happen when we're choosing between life-saving technology that can be applied to the next patient who comes to our ED or our next cancer patient versus this hypothetical. It's hard to make the case for it. But what can you do? Well, you can be flexible. You can be judicious with your purchasing folks to understand that the devices that you do get as you're cycling out new ventilators, new anesthesia machines, are they devices that have been thoughtful in their manufacture and in their handling, that they're suitable for managing emerging pathogen events? Can they be safely cleaned? Can they be decontaminated, disinfected? Are they durable for higher potency and intensity disinfection and cleaning? Those are the things that can be embedded now, even short of the idea of having a room somewhere in the hospital where you happen to have 50 extra ventilators lying around, because I just don't know too many CFOs or COOs who are going to be enthusiastic about that. I use the term center of excellence around collaboration in a generic way here, recognizing that the opportunity for collaboration locally and regionally is essential. Understanding even to the point, and we haven't actuated this in Chicago broadly, but even understanding where there's sensibility to it, can we understand what our colleagues are using at the hospital down the street, so that if we needed to resource share, do we think about having people trained on a different ventilator so that if we need to borrow from hospital B, that we can do so? So it's that kind of flexibility and collaboration. It's the encouragement of saying, once your capital budget request is turned down for those 50 extra ventilators, don't stop with it. Think about what you are buying, how can you make sure it's adaptable, and how might you collaborate with partner organizations, whether you're formally affiliated or not. You know, it's a slightly different story when it comes to, when it comes to supplies, because in some ways you can make the same case. For most organizations, not prudent or economical to stockpile critical supplies for emergencies. But I have to tell you, this is a little bit tougher one to draw a hard principled line on, because if you go back to the equipment, it's highly unlikely there'll be an infectious event where tomorrow any one of our organization, the 800 plus of us on the line right now, would need to consume all of our ventilators or all of our high-tech, expensive capital equipment to take care of a sudden influx of 20, 30, 40, 50 of those patients in the next couple of days. That being said, the supplies, personal protective equipment, medications, that can get exhausted much more quickly with even one patient. You see there again our training facility around Ebola. When we received a young child flying in who became febrile and nausea and vomiting on a flight from West Africa, and we took her on, we were glad we had some extra material around, some extra PPE around. The piece with it that becomes key is in these kinds of events, you want to have some degree of par level that's available to keep available to support routine and special operations for a defined period. The thing you need to remember, though, is whatever you consume now routinely for personal protective equipment, for example, if you have somebody in-house that people think might have Ebola or might have another highly contagious syndrome, believe me, your PPE usage is going to go through the roof. You'll be temporarily proud of everyone's compliance with PPE. So I do draw a distinction between that bigger equipment and the supplies, that if you have the space and you have the resources to stockpile some is reasonable, but what you don't want to get into in that collaborative phase is hoarding, and that can be seen, and I think many of us had that experience with Ebola. So what do you do for flexibility? Supply chain vulnerability. In the case of a large event, how do you maintain redundant supply chains? How do you ensure that you have policies and training that are not so adapted and specific for one particular gown or mask that if the need commands to change brands, to change a product, that you'll need to retrain everybody? So again, it's that flexibility, even if you're not stockpiling. And then the collaboration, again, the relationships you build now with the other institutions, with the great folks working in your local public health department, state public health department, CDC, becomes important to understand best practices, what their approach is going to be, but do be realistic. In a nationwide event, while you might say we're going to be prepared for 3 or 4 days and then we'll get strategic stockpile, that may not necessarily come. That being said, I think that early coordination and coordination during routine time with your contacts at public health becomes so essential to really understand that. the next most precious resource that we talk about is space, which is at a premium, I think, at all of our institutions for a number of reasons. And I want to, really send a real tribute out to folks and organizations that really dedicated themselves, in some cases before there was dedicated funding to do so, to say, we're going to have a space that we're going to keep preserved, mothballed, and ready to go when this comes out. And I think if you have the space and the organizational priorities that you can do that, again, I think it's fantastic. Most of us, including for us here at Chicago, we're not able to do that. We were not able to build out dedicated space either in the setting of any of these events or even going forward, even in a place where we're building new buildings. We haven't built that space. Now, we have, however, tried to build in some flexibility. So we look to that second place. So now as you're advocating, you're using all your influence, credibility, and communication to advocate that your new hospital pavilion is going to have dedicated space to take care of an Ebola patient or a pandemic flu patient, and it's turned down. It's value engineered, right, out of the plans. Well, there's still other options for you. There's a realization that how can you build in some safeguards in physical space so that while you may not be able to HEPA filter an entire building, that can you set up an area that can be repurposed, that can be geographically separated? For our suspected Ebola patients, we called it a pop-up unit, that we had dividers that came up, cordoned off a portion of the medical intensive care unit, and we turned that into a temporary Ebola unit, and by the time we saw our last patient, we could get it up in about 3 hours, which on a bad traffic day is about how long it takes to get from O'Hare down to the south side of Chicago. But collaboration, once again, becomes key, and understanding that even if everyone in your jurisdiction can't have dedicated units, how are you going to handle that next patient who comes in? How are you going to be ready? Because the time from when that patient hits your ED or your clinic or your OR to the time that they can be sent to a center of excellence or referral place is going to seem like the longest, scariest amount of time you've ever experienced. And if you're nervous about it, you can imagine how your frontline staff is feeling about it. So thinking about space, even absent dedicated space, really is essential. But of course, there's one resource that is absolutely in precious supply and is the most valuable one at every one of our organizations, and that's our people and our expertise. Now, would it be that we could actually recruit in the all-star team to populate all of our organizations to have us ready and prepared for all these events? It doesn't work that way, and frankly, there aren't enough of you out there to be able to do that. But what are the things that we need to do to bring flexibility to it, to realize that we're not all going to have emergency management clinical specialists available to us? It's to sit down and look at the stuff that affects us day to day and understand the extent to which it's going to be magnified in a time of crisis. Labor relations issues, work with trainees, issues around premium and hazard pay. How do we balance the needs of coercion and controversy, of working with union stewards and representatives? Those are conversations that can happen in advance of an event. Folks have their constituencies that they need to serve and protect, not to be obstructionist, not to serve as a barrier to patient care, and certainly not to be accused that they're a barrier to patient care. But they're conversations that we have in advance so we know where people stand and what they're starting from. What's our standard for premium or hazard pay? How can we be sure we're being consistent so that there's not inequity between the person who puts on a biosuit for somebody with suspected Ebola, but that we don't pay anything extra for someone who braves a Midwestern blizzard to get into work when there's a state of emergency on the roads to come in? These are conversations that can be prompted today. Ultimately, the roles and expectations should be distilled down, and this is where it comes into the Eisenhower quote. The idea of job action sheets can be very helpful in framing out expectations, but can never be seen as a script because we can't prepare in advance. But the idea of sitting down and saying, what would Sue's role do in an event like this? What would Tim's role do becomes really an important exercise, even if they don't become the checkbox that's being used on the day that those patients arrive. The staffing comment, that second, but the first bullet, ensure that all providers and staff are performing to the highest extent of their abilities and licensure. I lifted from my canned talks about value-based care, about quality, and about everything else we do in healthcare. This is a critical principle for how we work, And I think everyone in every role in a healthcare organization can point to circumstances where they're asked to practice below their ability and licensure. And not because and that's not bad because it's insulting or somehow disrespectful, but rather because it's not capitalizing our strength. It's not maximizing our people and expertise. So being deliberate and thinking about what those roles will look like. What's the right role for an infection prevention specialist? What's the right role for an infectious disease doc? That second bullet point, we were sort of struck. We arrived during the Ebola situation of saying, boy, the last person we want to have a spacesuit in the room is an ID doc. And remember, I say this, ID docs on the line. Remember, I'm board certified in ID. I don't need to be in that room. I'm not so great with the procedures. I'm not so great in moving around in that kind of suit to put in a line or to secure access. We opted for a model in which our intensivists really became the folks in the room, and the cognitive expertise around disease management stayed out of the room. People can arrive at different plans for that, and there's no right answer, but it shouldn't end up being a coincidence of who is at the bedside. It should have been thought out in advance. Another bullet point that should be applied in every presentation all of us make, whatever the subject in our work lives, is about resilience. There's enough in the lay press and in all of our professional literatures about how providers and support staff can burn out. Well, it's going to get magnified 100 times over in the setting of one of these events. And so understanding that and making sure that whether you're doing simulation to include the so-called B teams, because not every time something happens is you're going to have your top team. You know, the stuff is going to happen in the middle of, pardon me, a national meeting for intensivists. Or it's going to happen, when the trauma surgeons are away. That's when you'll have a mass casualty situation. And so understanding what's our backup plan is going to pay dividends when you get into these multi-day, multi-week events because it's exhausting, even if you're not the one putting on the spacesuit. Think about it now and apply it to your practice now, and it'll pay dividends. We've done the who. We talked a little bit about the what. Now let's talk about the how. This is now we're in the event. I can learn a lot about the demographics of the people joining the call if folks know who that is on the screen there. That's Al Haig, Alexander Haig. He was Secretary of State under Ronald Reagan, a public servant and a military guy of many years' service, but still distinctly known for one singular event in his career, sort of made famous on this Time magazine headline, which I'm surprised that he was probably not happy to see. But in the moments after President Reagan was shot in 1981, when there was uncertainty and there was a little question about how things were being run, in those initial moments, Alexander Haig very famously went to the lectern in the press room and said, "I'm in charge here." The only problem was that he wasn't. As Secretary of State, he was pretty far down on the chain of command, and it wasn't his responsibility. Now, where Alexander Haig came from was a place of command, authority, military familiarity, and an understanding that that power vacuum needed to be filled. I don't think anyone argues that this was a coup attempt by Al Haig, but it was an understanding that somebody had to be in charge, and he was going to step in if no one else could do it. There is an Al Haig at every one of your organizations today. These are good people. They're knowledgeable people. This isn't necessarily an endorsement of Al Haig politically, but just put that aside for a second. But there is an Al Haig at your organization who's ready to step in an emergency, and that might be a good thing, but it's an equally likely chance that it's not a good thing. And that competition and confusion about leadership needs to be reconciled before the event unfolds. If only someone would come up with a system of how we could organize governance in the setting of a crisis. Well, good news. The HIC system, a hospital incident command system, I will add my endorsement, what little it may be worth compared to all the many people who have endorsed it previously, as a singularly effective tool to be applied in the setting of hospital or health system emergencies, including infection prevention, epidemiological emergencies. It's form following function again, except in this case, the form has been designed by experts based on the experience and the functions that were needed in previous events. So the HICS command system is informed by events, more events than any of us, goodness willing, will ever experience at our own institution, maybe even our own careers. It's designed to be applied to all health care organizations with any kind of threat. It provides an organizational structure, but also in doing so a guide for planning, building, and adapting that structure. It's set for not only incidents that are surprise, but for planned events and sustainability. But maybe most importantly, that last bullet point, it's flexible, scalable, and adaptable. So go back to the Eisenhower quote. All plans are useless. Okay, maybe, but the Hicks command system has the adaptability to bring people together in a way to respond to virtually any kind of emergency. And we've been nothing short of thrilled with our strict application of it. A little bit more about Hicks now on this slide, kind of walking through some of the elements that make it successful. And I'll come back to some of these, but again, look at number 4, a flexible and scalable incident management system. It's modular, which means it can be adaptable to what's happening, but it allows you to fit in with other organizations. And when we get to the command structure with Hicks, you'll see, imagine if you're in a big city like we are, and imagine that all of your partner organizations have a similar organizational structure. It helps you understand who is who at those places, and so when you need to have those critical communications on the fly, that you know you're talking to the right person, they're in the right position to make that decision. This is the management team. The incident commander is designated at the top. Maybe that happens to be your Al Haig. Maybe it happens to be your CEO, but maybe it's not. Maybe that's not the most appropriate person, or maybe she's away. Look across, for those who aren't familiar with it, this is going to look to be an excruciating detail using what may seem to you to be unfamiliar or stilted language around operations, planning, logistics, finance and administration. Boy, that last right package, the finance administration, how often are we really thinking about that? And yet in a real disaster, real emergency, there's literally accounting that needs to be done to understand what was spent, particularly if there's going to be reimbursement coming from the federal government or elsewhere. Excuse me, pardon me. As we look at this, you might quickly look and say, but wait, where's all the clinical expertise? How are we running a health system without clinical leaders? And I'll draw your attention to a couple places. A medical care branch here, buried, some might argue, in the operations section, but then also these medical technical specialists up here. So how do we fit into this as experts in infection prevention? I'll tell you, back when I was in that first simulation I told you about, when I was sitting at the head of the table getting besieged with materials coming in, everything from we're out of canned pears to we need more doxycycline, I was the incident commander. That seemed pretty good as sort of a junior faculty member, new in my role, felt pretty exciting, but it wasn't the right place for me. And we only learned that later on when we adapted the Hicks system. So as we go forward, where would you find yourself as an infection prevention leader or healthcare epidemiology leader? I'd submit to you to be in one of these two boxes, either down here to the left in the medical care branch director or the medical technical specialist. Now I'll assert for you that which box you end up on has nothing to do with your experience, expertise, or position in the organization. It has to do with the nature of the event that's being planned for. So by way of example, in a primary bio or infectious incident event, I'd submit that the infection prevention or infection control and healthcare epidemiology should serve as the medical technical specialist. You need to have the ear of that incident commander, pardon me, so that she or he knows that there's no decision that's going to be made without your input, because that's how a critical decision could be made about planning, about operations, or about finance either, that you need to know about and you need to understand from that MTS position. But what if it's not an episode like that? What if we've opened up the Hicks system for a severe blizzard here in Chicago? Well, I didn't need to have our very capable healthcare epidemiologist or leader of the infection prevention program sitting in that medical technical specialist, because while there are clinical and I dare say maybe infectious implications of that kind of event, fundamentally that's not the right place for them. That's a place where we need to have folks who are working in continuity management, folks who are working in preserving and keeping the place open and running. And so in that kind of circumstance, the infection preventionist, healthcare epidemiology is still at the table. It's still at the table, but they're down in that operations branch, because maybe we're going to find out that the supplier who normally delivers our PPE for routine control of MDROs, maybe that supplier can't get their trucks in. And so what are we going to do in the meantime? So it ensures a place for us at the table, which fundamentally, how many times have you heard yourself saying that at your organization? I just want a seat at the table. Hicks compels you to do so. What have we and others found to be some of the benefits around Hicks? It's a rigorous application of structure. It compels people to obey authority. The scope of the event and the authority is very well defined, and it precludes the idea of last-minute substitutions of, hey, I got this idea on the way over here, so I implemented it. No, because the way HICS works is that team is meeting, either virtually or ideally in person, and they're cycling through a routine report structure that's timely, that's focused. This is cockpit-type environment. No extraneous language, no distractions, and we're going to get clear reports and expectations to be given. There's respect for authority. And then there's the possibility of adaptability, because you know what? This might happen in the middle of APIC. It might happen during ID week. You may not be there. It may be that new person you just hired who might be at the table on that first day, but we need to develop that depth at position. And so the chance to simulate in the HICS type environment becomes a really important element. Just an aside right now, because this is something that we can get called into as a very big decision early in an event. And this is, what are we going to do about our routine business and operations? And our signature for this is, are we going to cancel our elective knee patients because we have somebody coming from O'Hare, maybe with Ebola? Not sure. And so making those decisions is an early one, sometimes even before HICS has been convened. But in the setting of an epidemic or infectious event, you must be at that table. HICS can ensure that you'll be at that table, and this is where your credible and timely input is really important. Because again, it will be, and maybe some of you had the unfortunate experience of being discounted in that moment because of all the prior times when perhaps you've been less judicious in how you want to apply or how strict you want to be about some of these items. And again, that's tough to hear, and it's tough for me to say, but it's a reality of saying that in this moment, you need to have the position in the organization, as we talked about earlier, the effective communication skills, as we alluded to, and you hear about in the other webinars, and then in a structure like HICS, to make sure your voice is heard. Because if it's not safe to take care of those elective cases, if you need to cancel time off and holidays, you need to make sure that your voice is getting heard. And I think that one of the great services of HICS is it asks for that. But there's going to be that kind of decision is one in just a seemingly infinite number that would need to be made over the course of an event. Now, it would be easy and mathematically discouraging to a lot of us on the call to spend time talking about formal decision analysis. So let me just introduce this, because I have to confess, and maybe I should have put this in my conflicts, but I'm really enamored with decision analysis. And if I had my way, I would probably substitute something else in the first year of medical school training for formal training in decision analysis. This is a science, and it's a science that allows for rigorous and quantitative assessment of possible courses. Now, we're not going into detail here, but it's a recognition that with whatever input comes in, a decision does need to be made. And think of yourself around that HICS table. There's a new input. What decision? Does a decision need to be made? Even if it's no decision, but recognizing the decision to not act has its own consequences. You look at the probability of different events happening. What's the likelihood that this girl's being transported from O'Hare actually has Ebola? What's the likelihood that she's still vomiting? What's the likelihood that she may need to be intubated? And each of those likelihoods can be plugged into a map or a tree like you see on the left and help weight the outcomes to understand where you need to put your resources, where you need to put your time. If nothing else, decision analysis, and again, I encourage folks, and you can go online, there's a lot of professional society work and elsewhere and in the primary literature to look at this to get that kind of introduction. But if nothing else, it requires discipline and clear communication, which is always going to serve you well in the otherwise potentially chaotic environment of a cluster and outbreak. Folks talk about analysis paralysis and are we going to dig in? There's something to be said about don't just do something, stand there. Pause and understand what's happening. And I'm not talking about as a patient's decompensating in front of you in your clinical practice, but I'm talking about ensuring that we don't make a decision offhand that's going to contaminate an area or expose a set of our colleagues. And so sometimes I always err on the side of pausing to consider a robust analysis rather than jumping into it. But of course, we're not always going to be able to build decision trees. I'm a realist too. And so my team here has heard me echoing this, I think, from the first day that I was in the infection control job, where I probably realized I was in over my head and I needed a framework for dealing with everything that was coming at me. And I found myself saying, when in doubt, let's do what's rational, practical, and equitable. With the information we have right now, is this the best decision we can make? Is it rational to follow the course we're going to follow? Is it practical? Because it's fun to think about how we put everybody in isolation or put a monitor outside of every room, but we may not be able to do that, in which case we need to discount that option. And then for me, what's really the important was, is it equitable? Does it really take into account the values of our organization, our providers, and the population we serve? So even if you're not going to dig out the decision tree, even if you're not going to do the complex math around sensitivity testing on decisions, I'd encourage you, just think, when in doubt, is this rational? Is it practical? Is it equitable? And that's now 15 years ago, and I've never felt poorly served when I've applied this in every job that I've been in and every decision where I felt maybe overwhelmed. But ultimately, it's not about us. It's not about us as leaders. It's not about executives. It's not about experts. Ultimately, the decisions that lead to success or failure in managing an event like this is not going to be made by us. It's going to be made in the moment by professional and non-professional staff on the front lines, and that's the product of ongoing communication, culture, and trust. And the benchmark for this, in my mind, is without supervision or without clear policy or practice guidance, will our team member make the right decision? And I'm always touched, with the Ebola experience, which was formative for us as an organization, even though we ultimately never saw real Ebola patients. But in one of the patients, the results came back from CDC, or at that point maybe from our state health lab, that said the patient was clear of Ebola. And so we were able to come off precautions. And it was noted that in the room, every single provider who had been caring for that patient, when they were told they could take those precautions off, followed the exact protocol, the exact standard that had been established for caring Ebola patients. It was so ingrained in them in doing the right thing that even in that moment, there was only one patient in our whole hospital who we knew didn't have Ebola, and it was the little girl in that room. But every one of them did it as they were trained and did it as they were instructed to do it and did it without questioning it or asking it. And I'm not asking for blind faith. I'm asking rather to trust the people we have on the front lines, the people that our patients really entrust with their care, to do the right thing. And how do we as leaders and content experts get them to that point? That's what I think this is really all about. So we come to conclusion on all of this. And as we reflected on some of those near-biblical events that we've experienced here at the University of Chicago, we sort of, as we debrief and perhaps over, a little bit of intoxicating liquid, we think about, why did that go so well? Why did the same people that we feel conflict with and at times dissonance with in our daily management, why do we pull that off so well? How do we take care of that kid with vaccinia, with eczema vaccinatum so successfully? How do we manage those potential Ebola patients? How do we handle the follow-up to the plague death and all the other things and the less dramatic events that you've all experienced? How do we get through that blizzard? And to step back and say, there are things we do in that moment that we need to do every day. So we mocked up here. This is as if this was the cover of a Harvard Business Review or something like that. Ebola management. Not managing the disease of Ebola, but what are the skills in management that we bring to clusters and outbreaks that we need to apply every day? Because when we broke it down, what we see is we feel aligned as a leadership team and as providers. There's a singularity of purpose, and that singularity of purpose is aligned to our patients and their families. We're aligned with our missions and values. We don't have the time to constantly be back-checking and sniping at others' expertise. We have to respect the people who handle environmental services know what they're doing better than I do. And we have to have respect and trust in them. We have to be disciplined in our decision-making. We have to be very, very clear and effective in our communication, and a recognition that when you're faced with uncertainty as a leadership team or a clinical team, there's a realization that no one's expert in the room, and that our best option is to band together. And I'd submit to you that whether you're dealing with an outbreak, or you're dealing with your next financial crisis, or you're dealing with your next problem with capacity, or your next problem with clinic issue, this same approach really carries through. So I hope in going through this today, we've not only framed a little bit more around communication and the urgency and how you can position yourself for success, but hopefully given you and allowed you to start thinking and talking with your own teams and each other about what are the kind of tools that we need to develop, not just for those moments of crisis, but for all the other moments of our day and our career that keep us out of crisis. So David, I'm going to stop with that, and I think we have about 30 minutes left for questions. I'd be happy to open up. And again, I want to thank everyone for joining and thank everybody for your patience with some of the technical issues. So, David, I'll go quiet for a moment and turn it back to you.
All right. Thank you very much, Dr. Weber. That was really an outstanding presentation on a very important topic. In terms of questions, any of the webinar viewers are hopefully able to submit questions through the chat tool, and those questions will be sort of passed along, and then I will relay those to Dr. Weber as they come through. I do want to remind the group that this webinar has been recorded, and the recording is available through a link through the chat tab and also through the SHEA ORTP website. You'll be able to access the slides and the audio recording. So looking at the questions coming through for the talk, I think one question that always comes up is about sustainability. How do we go about sustaining our preparedness for these for emergency events? A lot of times there's a sudden burst of preparedness around a particular event, but then over time, as you alluded to in your talk, fatigue can develop. So do you have any tips on how to sort of sustain such a high level of preparedness among individuals who are going to be potentially called upon for these situations?
No, I think that's a great and important question. I wish I had addressed it in the prepared remarks, because you're right. It's a critical one for most. In many ways, adopting an infection model, it's as if periodically organizations need to be re-inoculated to maintain our preparedness to fight off these events. I think for folks that have really devoted themselves to the HIC structure, because of the adaptability of it, you don't have to wait for the next plague event to exercise yourself. And so I mentioned, I think, in the talk that we've uncorked our HICS command center in the setting of everything from blizzard to potential labor disruption to a new hospital pavilion opening. And I think that much of that, David, gives you the chance to exercise some of those generic management skills that I talked about, particularly at the end. As far as for the specific preparations around infection prevention and epidemics, it does come down to the simulation and training in that way. And what I encourage folks to do, and this is, I recognize, contingent on where you're at and the resources that you have, but there's partners in your community who want to engage in this too. Some of them are going to be other healthcare providers. Some of them are going to be community agencies, certainly public health, to try to make it a premium with them. It doesn't need to be a multi-million-dollar dark winter type exercise, but to come in, it's the expensive lunch to sit down and talk through over a few hours, what would this look like in our community if we had a patient like this come in? And again, what it lacks in polish, it will make up for in collaboration and relationship building. So again, I know that's a little bit of a hedge answer, because we all face that, but it's the deliberateness of not waiting till the next event and trying to apply some of the skills more broadly.
All right, great, thank you. A question actually just came in about how to identify volunteers for an Ebola team or some sort of emergency preparedness team. It sounds like the person submitting the question had some difficulty with that particular task. So do you have any advice as far as how to identify and secure a team that would be activated in an emergency setting?
Yeah, and I think if this were an even more open forum, I bet there are other folks on the line who could speak to this as well, because every organization is a little bit different. I think the first bit of advice is you need to know what you're looking for too, because if we were looking exclusively for one set of providers, we may have limited ourselves. We developed what were the skills we needed. We thought we needed people who would have procedural skills among the physicians, and certainly the nurses around technical proficiency around procedures. We wanted folks who were accomplished in bedside diagnosis of evaluating the decompensating patient. And we wanted ideally to try to preserve teams where we could. It's one of the reasons that we leaned heavily on our intensivist group, because we ended up taking pediatric and adult intensivists along with and led by nurses from the same units, because there was a familiarity in those groups working together. Now, that's coming from a position of, gee, what if you have too many volunteers? What if you're short in it? Know what you're looking for, one. Start looking well in advance of the event. Because if you've identified in the hypothetical somebody who says, yeah, I'd be willing to pitch in, I mean, to be perfectly honest, when you sit down with them, when the event unfolds, in essence, the requirement begins for them to pull out rather for them to volunteer. So if you started today and said, we wanted to convene an emergent outbreak care team, what's it for? We don't know. It could be for Ebola. It could be for pandemic flu. To start talking through it now, so those people, you can address your questions and issues in securing that team. Because you may find out outside of the setting of an event, hey, I'm willing to do this, but I'm going to need some hazard compensation, or I'm going to need some protection from other responsibilities. I'm going to need help with child care if I'm going to be doing this. You want to address that early on and understand what the barriers are. In populations that are enriched for volunteerism, many American hospitals, and I'm sure the same is true overseas too, have folks who are retired, active duty, National Guards. These are folks who often have training and a spirit of volunteerism that brings them to the fore. So we know through HR folks who are involved in the military, or actually we know generally from folks from the scheduling, the work that they do. And that was a group that we went to, and that ended up being really helpful in not all of them were able to volunteer, but they were able to help us to understand the mindset of what might be required. But if there's a singular answer, David, to that really good question, it's I'm not sure there's a single way to go about it, but the only time you should not be trying to do it is when you're waiting for that first patient to arrive. It's too late at that time, and so the work you can do now becomes essential.
All right, great. Thanks for that response. So there's a question that came in. I think we recognize that you are coming from a sort of large tertiary or quaternary academic medical center, but what about those facilities that may not be as adequately resourced as your facility, potentially thinking about healthcare facilities outside of the acute care hospital? Do you have any advice for how to help those types of facilities and provide some guidance as to how they can develop an emergency preparedness plan and communicate effectively in a sort of similar way?
Yeah, and I'm glad that's brought up, because and I hope it came through that it's not lost on me the good fortune and the blessings we have in terms of where we're at and what we're doing. But it's part of the service. We need to understand how this can protect all of our patients collectively as a society, and certainly all of the frontline providers. I think when you look, there's first of all an important acknowledgement that even in a world where we might designate centers of excellence, that we might pile resources into a fixed set of institutions across a region or across the country, patients don't abide by those referral patterns, and it's impossible to know that a patient with Ebola might not come to misread the sign and come to your ambulatory surgery center, or might come into a freestanding emergency care clinic. So no matter what setting it's in, there's a degree of recognition that there needs to be some degree of preparedness. I will tell you that as you go in, if you haven't looked at the Hicks literature and the Hicks work, and that you saw some of the links that were on the slides, and the slides are being made available, I know, is the reality of that forces you a discipline to say, what do we have, what do we not have? Where might we need outside help? Because when you go back to that slide that shows that organizational structure, there are plenty of places that don't even have a leadership team big enough to fill in all those boxes. But at least in trying to populate that kind of tool, it allows you then to start understanding where your gaps are and where you might need to get outside help, either in the moment or in preparation. And sometimes it's not going to involve, and generally won't involve, a new hire, which you don't have the resources for, a consulting engagement, which you may not have the bandwidth or the resources for, but it may be some learning. It may be a time away at a weekend program where someone's understanding a little bit more about the finances that accompany an event. There is a cottage industry that's developed around a lot of this work, and while I can't provide any specific endorsements, I encourage folks to go out there and share through your own professional networks tools and resources, books, online stuff that's going to be helpful. But it's a fantastic point, but that's why I really have become so enamored with Hicks, because it lays it all out and helps you understand the gaps.
All right, great. That's very helpful. And I don't know, along the same lines, can you sort of share any experience you may have had in working with those types of facilities, or any advice to individuals who are working in an acute care hospital about sort of building relationships with those sort of other types of healthcare facilities in order to maximize and prepare yourself, knowing that there could potentially be patients transferred between different facilities. So is there any opportunity that you can see for the acute care hospital leadership to develop those relationships and build preparedness network?
I think it feels like it should be an old Irish blessing of may you never meet your colleagues in a crisis. You want to establish those relationships in advance and under whatever guise. It doesn't mean that you need to say, hey, we're going to do a citywide retreat about Ebola preparedness, because on busy schedules, that may be hard to do. A lot of our relationships in the Chicago, the physician community around infection prevention, stem back to a lot of the collaborators at the bigger centers were taking part in what was then called the Chicago Healthcare Epidemiology Roundtable, a needlessly complex name and acronym that just meant once a quarter we were getting together, having some lunch or breakfast, talking about tricky things, talking about tricky cases, interacting with folks from the Department of Public Health. In many ways, we were sort of envious of some of what was happening in the local APIC chapters of where we had folks who were coming together and sharing. And so it's an early move, David, to try to generically break down the barriers of sort of kind of the bias against transparency that sometimes exists in our field. We were greatly blessed and absolutely supported by folks in the Chicago and Illinois Department of Public Health, who, again, if your relationship historically and unfortunately has been one of somehow some tension or oversight with those groups, these are clinically minded people who care about your patients as much as you do. And trying to get over whatever recriminations came about over a previous site visit or what have you, go meet on neutral territory and sit down and just start getting familiar with these folks and how they work, how they think about things, because it's going to allow you to start anticipating each other's expectations so that when things start to unfold, you're already starting to meet. So again, I don't feel like you need to kick off by saying, hey, we're going to form a 3-state collaborative around emergency preparedness. More often than not, David, I think it can start with, hey, let's go out for lunch. Or, hey, there's a speaker that's coming to this other institution. Let me call up my colleagues who come to other places, and maybe we'll all go over and hear her speak and then meet for coffee afterwards and just get it going. I mean, this sounds really ridiculously simplistic, but I think it pays enormous dividends later on, and not just in these outbreaks.
That's great. No, I think that's really important advice about really the importance of collaboration and sort of understanding your region and being able to build those relationships among neighbors, because this is really all a challenge that we share together in maximizing our preparedness. So at this point, we don't have additional questions coming through. So I do, again, want to remind the audience that this webinar and the Q&A have been recorded and are available on the ORTP website. And our third webinar in the series will be on July 11th, 2017 from 12 to 1:30 with Taylor Wilson from Nebraska. Is going to be giving a talk on beating the media crush during a crisis. So that should be an outstanding talk. And lastly, a thanks to Dr. Weber for an outstanding presentation, and we are very grateful and are very enthusiastic about this webinar series. So thank you again. And again, if anyone would like to access those presentations, they're available through the SHEA ORTP website online, and the link you can see is in the chat box as well. All right, so thanks again, and we'll look forward to you joining on July 11th.
Thanks very much, David, and thanks again to everyone who joined.